Single level fusion done at the ASC. This patient had neuroforamen stenosis. See it on the x-ray, but certainly more significant increases on the MRI. And you can see how collapsed the disc was on the pre-op x-ray. So the typical procedure is done through a paramedian incision using the standard tubular systems, whichever you like, and do a incision about 2.5 fingers, breaths off of the midline. One thing very, very important if you're doing a T-lift is to have a trajectory with this that is angled enough to get your implant at the midline or just a little across. I'm doing a complete facetectomy, variable amount of laminectomy, depending on if it's all neuroforamen stenosis and no lateral recess, then I'll do very little laminectomy and mainly through the foramen, or I may be extending, a hemilaminectomy, or if it's a bilateral stenosis, then I'll use that technique of going across the midline from the unilateral approach, doing a bilateral decompression. So the decompression is based upon what the pathology is. So after the decompression is done, then I'll come into the foramen again, incise into the disc, scrape up the disc space to remove the disc material. I feel very, very secure with just the standalone implant. So we were able to get a nice elevation of the disc space height, significantly the foramen height restored. You can see a very nice height restoration of the foramen, which is the objective here. The implant could be a little bit more angled, but it's quite adequate. Certainly the earlier cases, when I was the learning curve, I had way too many of the implants that were too lateral on, they were as medial as I could get them. You just can't get them medial enough if you're using a very small incision from a midline. So I certainly recommend if you're going to go minimally invasive to a small wound that you do it paramedian. Obviously, if you're doing an open type procedure, then that's irrelevant. I typically use a wound drain in the epidural space. Typically use a lumbar brace afterwards. I used to do the T-lift expandable cage type devices with bilateral pedicle screws for years for these same cases. And this standalone is just so much quicker. And the vast majority of people have not needed supplemental augmentation down the road. Very, very few.